Hello everyone. So today we will be discussing amenorrhea and the disorders of the sexual development. So here comes our first slide. It shows that actually the developing embryo actually has the ability to either develop the gonads into the ovary or into the testes. So the gonads are actually, they have the bipotential and the presence of SRY gene determines whether that it will develop into the testes or the absence of the SRY. So basically it is the SRY gene that actually determines what will the gonad develop into, whether it would be an ovary or the testes. So if there is an SRY gene that is actually only present on the short arm of the chromosome Y, the gonad will develop into the testes. Here you can see that this is a bipotential gonad, and we have the Wolffian duct as well as the Mullerian duct. So the presence of the SRY gene, which is located on the short arm of the Y chromosome, the SRY gene is also known as the testicular determining factor, TDF. So what happens is that in testes, so it will develop into the testes. What happens is that in testes, we have two kind of cells, that is the Leydig cells and you have the Sertoli cells. So the Leydig cells, they produce the testosterone, and the Sertoli cells, they produce the AMH. So you can remember it like Leydig cells, say like LT. LT is the Leydig cells produce the testosterone. And what happens is when there is a testosterone, it helps in the growth of the Wolffian duct. So the duct shown in the blue color is the Wolffian duct, and blue is for males. So you remember this blue is the Wolffian duct, and if there is the development SRY gene, there will be the development of testes, and the testes have two kind of cells, the Leydig cells and the Sertoli cells. So the Leydig cells, they secrete the testosterone, and this testosterone actually helps in the development, in the growth of the Wolffian duct. And what happens that the Sertoli cells, they secrete the AMH, the anti-Mullerian hormone. So the name describes itself that it will act on the Mullerian duct and it will cause a regression of the Mullerian duct. So the baby will develop into the male side, no? It will develop the testes. So here, because of the Wolffian duct. Now coming on to our next side, that is the female, what happens is that there are no SRY genes, so there will be no regression of the Mullerian duct, because if you have the SRY gene, it produces testes, and the testes secrete the testes have the Sertoli cells which secrete the anti-Mullerian hormone. So at this time, the female doesn't have any anti-Mullerian hormone, so the Mullerian duct will continue to grow. Now, coming on to back onto the male side, that you have the testes. Now what happens is that this Wolffian duct gives rise to the, you can see, it gives rise to the epididymis, to the seminal vesicle, to the vas deferens, and the ejaculatory duct. So these four things develop from the Wolffian duct. And coming on to the female side, you can see that there is the Mullerian duct, which has the form, and the Mullerian duct gives rise to what? Gives rise to the proximal two-third of the fallopian tube. Then from fallopian tube, you come to uterus, it gives rise to uterus, then you go down cervix and the upper two-third of the vagina. So what remains is the lower one-third of vagina, so it develops from the urogenital sinus. Okay, now what happens is, okay, so one thing we have missed is that the Mullerian duct is also known as the paramesonephric duct, and the Wolffian duct is known as the mesonephric duct. Now coming on to the external, what happens that the Mullerian duct has given rise to the internal genitalia as well as the testosterone. The Wolffian duct has given rise to the internal male genitalia. Now, what happens, how there is a development of the external genitalia. So external genitalia may, if in utero there is the exposure of the testosterone, then obviously it will give rise to the male external genitalia. And if there is no testosterone, then obviously there will be development of the female external genitalia. So I have already explained this, that in testes you have two kinds of cells, the Leydig cells that secrete the testosterone, which acts on the Wolffian duct, also known as the mesonephric duct, and Sertoli cells that secrete the anti-Mullerian hormone, which suppresses the Mullerian duct, also known as the paramesonephric duct. So the internal development, genitalia development, how it occurs that in females there is no AMH, so Mullerian duct forms. The proximal two-thirds of the fallopian tube, uterus, cervix, and the upper two-thirds of vagina, whereas the lower one-third of vagina is formed from the urogenital sinus. And external genitalia develops because of the exposure of the testosterone. So if there is testosterone exposure, there will be male external genitalia development, and no testosterone means that there is development of female external genitalia. Now, what is amenorrhea? Amenorrhea is actually the absence of the menstruation for more than 6 months in the absence of pregnancy in a female of a fertile age. And whereas oligomenorrhea is that irregular periods at intervals of more than 35 days with only 4 to 9 periods a year. And the cause can be hypothalamic, pituitary, ovarian, or endometrial. And the amenorrhea and the oligomenorrhea, they both can be secondary or primary. So coming on to the amenorrhea classification, there is physiological amenorrhea and it can be pathological amenorrhea. So in physiological, obviously you can think it from your obviously the common sense you have been given to 5 years of medical, that it can be pre-puberty time, it can be pregnancy, it can be lactation, and it can be cause of the menopause. What are the pathological causes? Pathological are primary and secondary. So the primary are actually true and false, and secondary की बात करेंगे. So what is the hypothalamic pituitary ovarian axis? For the menstruation to occur, you need to know that hypothalamic pituitary ovarian axis is very important. What happens is the hypothalamus actually releases the gonadotrophin releasing hormone in a pulsatile manner, and which acts on the pituitary. Now, pituitary releases the gonadotrophin, that is the LH and FSH, which stimulate the ovary, and the ovary as a response secrete the estrogen and progesterone, which acts on the uterus, and the withdrawal of these hormones actually results in the menstruation. So what happens is, if there is some negative feedback of this estrogen and progesterone, there's a negative feedback. If they're produced a lot, obviously it will give the negative feedback to the pituitary to stop producing more LH and FSH. Okay? And you should know that what happens is that pulsatile gonadotropin releasing hormone, it actually requires leptin, kisspeptins, and glutamate. These are the positive factors which cause the pulsatile gonadotropin releasing hormone to act on the pituitary to release the gonadotrophins. So in obese girls, leptin is present. So the obese girls, they menstruate earlier. The menarche occurs earlier than those who are lean. And the inhibitory factors on the pulsatile gonadotropin releasing hormone are the GABA and the neuropeptide. So we have discussed that they are primary and secondary amenorrhea, and in primary you have false and true. So this staging, you must know that the first during development there is a growth spurt, then there is the thelarchy, which is the breast development, then there is the pubarchy, that is the development of the pubic and the axillary hair, then there is obviously the height and the menarche. So for this mnemonic, you should remember a mnemonic that is GBP, that GBPH and M. So the it gross benign prostatic hyperplasia in males. So इससे you can remember the pattern. Now coming on to the next, you have the false primary amenorrhea. In this, what happens is that the female has all the secondary sexual characteristics, and there is no hypothalamic pituitary ovarian axis problem, And the patient, the girl, is phenotypic, typically female. Obviously, the karyotype is 46XX. Patient or the girl has female gonads, that is the ovaries, and the only problem is that the patient has outflow obstruction. The female will experience the cyclical pain every month in the abdomen, and the only problem is that there is the outflow obstruction. So anything that is causing outflow obstruction will lead to the primary false amenorrhea, also known as the cryptoamenorrhea. So the causes can be the imperforate hymen, the transverse vaginal septum, cervical atresia, or cervical stenosis, or the vaginal atresia. So what is the cryptoamenorrhea? That the patient, the girl, has a primary amenorrhea, and there are well-developed sexual SSCs, secondary sexual characteristics. And because ovaries are present, so there is no problem in the development of the characteristics. And the girl is menstruating every month, but the problem is that there is the outflow obstruction, like perforate hymen, and there's a cyclical pain, and the blood accumulates in the vagina. So you can see that there on examination, you can see there's a tense bluish area on the bulge. You call it hematocolpus. Hematocolpus is that the blood collects in the vagina. And when this collection is increased, it can cause the you can see there's a urethra. So you can actually this hematocolpus can compress the urethra. The girl can present in emergency with acute retention of the urine. And when this blood goes into the uterus, back goes into the uterus, it causes the hematomitra. And when it goes into the tubes, it can cause hematosalpinx. And in the pelvic cavity, obviously, this is the endometriosis. Now, on the local examination, you have seen there's a dense bluish area. What is the management? That you give a cruciate or an X-shaped incision on the bulge of the hymen and drain the menstrual blood out. Now, yeah, I have already explained these all. Now, coming on to the problems of the HPO axis and obviously the disorders of the sexual development, you need to know that obviously a problem may lie in any of these things, the uterus, the ovary, the pituitary, or the hypothalamus. So we'll start from the hypothalamus. Come use to understand this thing, that if there is a problem in the hypothalamus, it means that the gonadotropins are not releasing, the gonads are not developing. So it is the hypogonadotrophic hypogonadism. And the example is the Galman syndrome. Going on to the pituitary, also that the gonadotropins are not secreting in an appropriate amount, and obviously the gonads are not developing because of that. So it can be because of the prolectinoma or the craniopharyngioma. Going on to the ovary, now what happens is that all the HP axis is okay, but what happens in the ovary, that it is not responding to the gonadotropins. That gonadotropins are produced in a large amount, and there's hypergonadotrophic hypogonadism, that the gonads are not responding despite of a lot of FSH and LH, and because there is no release of estrogen progesterone, and there's no feedback to the gonadotropins, so they are increasing, they're at least increased amount, but the ovary is not responding to them. So this state is known as a hypergonadotrophic hypogonadism. And what happens in the uterus, that the HPO axis is absolutely fine, the gonadotropins are releasing, the gonads are okay, but the uterus is not responding to them. The uterus is either absent or hypoplastic. So this is MRKH or AIS-TFS. We will be discussing it in the next slides. So this states the eugonadotrophic eugonadism. Now coming to the hypogonadotrophic hypogonadism, that is of the pituitary and the hypothalamus, that it is central, it may be constitutional, and other causes must be excluded, like anorexia nervosa, excessive exercise, or chronic illnesses such as the diabetes or renal failure, and the causes include a pituitary tumor or the Galman's syndrome. And in this, the patient, the girl, may present with delayed puberty or the primary amenorrhea. Now, what is hypergonadotrophic hypogonadism? I have just explained. It is because of the gonadal failure, the gonadal agenesis or dysgenesis. There are high gonadotropins, but the gonad doesn't function, and it is associated with the Turner syndrome, the XX gonadal dysgenesis, the premature ovarian failure. and it is associated with delayed puberty in the primary amenorrhea. And it can also occur later in life and because secondary amenorrhea after normal sexual development. Now, what are the non-structural causes of the disorders of the sexual development? The most common cause of the primary amenorrhea is the Turner syndrome. Okay. So first, you need to know what is the karyotype. When we will be discussing every disorder, we will be discussing four main things, four or five main things: the karyotype, the phenotype, the gonades, and the sexual characteristics. So the karyotype is 45XO. There will be no bar bodies. And the phenotype is female, no bar bodies because we don't have any X chromosome. That X chromosome but has the bar bodies. So 45XO, bar bodies nahi hongi. The phenotype is female. The gonads are present, but these are the streak ovaries. And the sexual characteristics do not develop because there is no estrogen. The ovaries produce estrogen. So if there are no ovaries, the streak ovaries, it doesn't produce the estrogen, and there will be no development of the sexual characteristics. And there is an infantile uterus because for uterus, you require estrogen. So as a result, no uterus. What are the characteristics of the patient, features of the patient, that the Turner syndrome girl will be short-heighted, webbed neck, and the large carrying angle, widely spaced nipples, flat chest, and what more, that cubitus valgus, okay, the short foot metacarpal, and the most common, the most characteristic of the heart disease, what happens is in Turner syndrome, there's a coarctation of aorta. There's a coarctation of aorta, and there will be inflammatory bowel disease, the sensory neural and conduction deafness, there can be renal anomalies, and the endocrine dysfunction like autoimmune thyroid disease. So how will we manage the patient? We require lifelong supplementation of the estrogen and progesterone. Why progesterone? Because the uterus is present, there's an infantile uterus, but it is present, and if there is an opposed estrogen, it will cause endometrial hyperplasia, it will cause endometrial CA. So you need progesterone too. And the sexual characteristics can develop now, and menstruation also can happen, but no own genetic child. Coming on to the next, MRKH, or the Mullerian agenesis. What stands for the MRKH? MRKH is Mayer, Rokitansky, Koster syndrome. So we'll be calling it MRKH to be, short. And first of all, we'll discuss the karyotype. So it is 46XX. The phenotype is obviously a female, and the gonads are actually ovary, and secondary sexual characteristics develop. Why they do develop? Because you have the ovary, the estrogen is present, and the sexual characteristics develop. But the girl doesn't have vagina. Either it is a hypoplastic vagina, or there's hypoplastic uterus or no uterus, and there will be either no vagina or short blind vagina. There's upward movement of vagina in this case, and it is associated with the skeletal and the renal abnormalities. And the management is that vaginoplasty. Just before marriage, you go for vaginoplasty. Either they can be mechanical dilators or McCondy or Williams vaginoplasty in these cases. And these girls can have their own genetic child with the surrogacy because they do not have the uterus to carry the baby, but they do have the ovaries, so they can have their own genetic child, but with surrogacy. So there are only two conditions in which there is absent uterus and short blind vagina. These are the MRKH, or the androgen insensitivity syndrome. And how do we differentiate in between these two is the karyotyping. Coming on to next, we'll discuss that how do we rule them out, because karyotype of the MRKH is the 46XX, whereas the androgen insensitivity syndrome, you have 46XY. Now, we're coming to the 46XY, that is a complete androgen insensitivity syndrome, also known as the TFS, testicular feminization syndrome. And because of the SRY gene, you have the karyotype of the 46XY. Now you know Yours, so the patient, the phenotype is female, but the karyotype is 46XY. And now you have the Y gene. So gonads will be testes, no ovaries. The ovaries absent, uterus absent, and short vagina. So secondary sexual characteristics do develop. Why? They develop because there is the testosterone receptor defect. So the testosterone will be converted into the estrogen. So you have the estrogen, there is the development of the sexual characteristics, but there are no pubic or axillary hair, external genitalia, female because of the no testosterone receptors. So this is a female with a blind vagina. I just forgot to mention that the MRKH girls, they are very beautiful, and they're very beautiful, but obviously the phenotype is a female, the karyotype is 46XX, but they do not have lupus or there's hypoplastic lupus. So, coming back to our the androgen insensitivity syndrome or the TFS, that is a testicular feminization syndrome, the 46XY karyotype, and because they have the Y gene, so there will be presence of the testes, but the secondary sexual characteristics develop because testosterone receptors are not present. The testosterone will be converted into the estrogen, and there will be secondary sexual characteristics. There will be no axillary or pubic hair, and the external genitalia will be of female and the female with a blind vagina. So testes are found somewhere in the inguinal canal or in the pelvis. And obviously, this testes, they can cause a malignancy, some on later in life. So seminoma. So what happens that when you go through a puberty stage, when the secondary sexual characteristics have developed, you go for gonadectomy. And obviously, after that, you need long-term estrogen. You do not need progesterone because there is no uterus. So you can give estrogen long life. Now, coming on to our next slide. So the management. Management is obviously you go for the gonadectomy and you go for the vaginoplasty. Now, coming on to the Swyer syndrome, that is the 46XY gonadal dysgenesis. You know that it is the Y gene, SRY gene is present. The phenotype is female, the gonads are streaked gonads, and the sexual characteristics do not develop. Why? Because they're streaked gonads. They do not produce the estrogen, so there are no estrogen, no characteristics. And uterus is present because AMH is absent. Anti-mullerian hormone is absent, so uterus will be present because anti-mullerian hormone actually what causes it absent when the anti-mullerian hormone is not present. When it is present, then there will be no, then it will induct agenesis, dysgenesis. But obviously the AMH is absent because so the uterus will be present and the streak gonads, there will be streak gonads. Now, lifelong management is with estrogen and progesterone because you have the uterus. So, progesterone bhi dena padega. And coming on to the next. So, we have missed one topic in between, that is the Kalman syndrome. Kalman's may we have already discussed, that is a hypothalamic defect, and that is a Kel gene defect. And the karyotype is of the 46XX, and there will be anosmia. Gonads will be present, the ovary will be present, and the uterus will also be present. But there will be no secondary sexual characteristics because obviously gonadotropin releasing hormone is absent. There is no HPO excess. So the gonads will be present, the uterus will be present, but there will be no secondary sexual characteristics. And treatment is that you give pulsatile gonadotropin releasing hormone to the patient, and because it is very expensive, so the other line of treatment is injection HCG. And now coming on to our flow chart, which is really important, and the summary of our whole lecture is that you take a detailed history and the physical examination of patient with a primary amenorrhea. Now you will see that when you examine the patient, you see that the patient has the secondary sexual characteristics. If the sexual characteristics are present, then you go for the ultrasound to see whether the girl has uterus or not. If the uterus is present and it is normal, obviously then there may be an outflow obstruction, either an outflow obstruction or not. If there's outflow obstruction, then it can be imperforate hymen or the transverse vaginal septum, and if there's no outflow obstruction, evaluate for secondary amenorrhea. And now you have performed the ultrasound and you see that the uterus is absent or it is abnormal. You go for the karyotype analysis. We have already discussed that there are only two conditions in which there's uterus absent or abnormal. And for that to rule out, we go for the karyotype analysis. And if it is 46XX, it is a Müllerian agenesis, and if it is 46XY, it is the androgen insensitivity syndrome. Now, if the secondary sexual characteristics are not present, then you go for the LH and FSH test. If the LH and FSH are less than 5, that it means that the gonadotropin releasing hormones are not released. There is hypogonadotrophic hypogonadism, that is that the problem lies either in the pituitary or the hypothalamus. And if there is FSH is more than 20 and LH is more than 40, then obviously the gonadotropin hormones are actually they are present. That is the hypergonadotrophic hypogonadism, and for that you go for the karyotype analysis. Karyotype may, if you have the 45XO, it is a Turner, and if it is 46XX, it is a premature ovarian failure. So it is all for now. So I hope I have made all these things clear. Thank you.